Good evening, everyone. On behalf of IACM, I extend a warm welcome to all of you. You will be happy to know that today is the 10th of our national online CMEs. The topic tonight is dyslipidemia and its management and India-centric approach. For those who are joining us for the first time, I'd like to inform them that these CMEs will be held regularly on the first Thursday of every month from 8 p.m. to 9 p.m. The guests of honor for today's program are Dr. K.K. Parikh sir and Dr. H.S. Pathak sir. Dr. K.K. Parikh sir needs no introduction at any forum. He is past President API, past Dean Indian College of Physicians, and the immediate past President of IACM. It was his foresight and dedication that has led to the creation of 3 state chapters in a span of few months: Rajasthan state chapter, Gujarat state chapter, and the Tamil Nadu state chapter. It was also his idea to have these CMEs. He has held my hand in every CME, and he is the heart and soul behind these CMEs. The next guest of honor is Dr. H.S. Pathak sir, a legendary clinician, a humble, soft-spoken, and an able leader. He is the current president of IACM. Under his vision and able leadership, we will soon be starting online clinical case discussion, which will again be held on the third Thursday of every month. The next clinical case discussion would be on a nephrology from nephrology department of SN Medical College, Agra. We welcome you, sir, and are honored to have you with us and are blessed to have your guidance with us. The chairpersons for today's program are Dr. Anil Kulshresh sir and Dr. S.N. Narsingan sir. Dr. Anil Kulshresh sir has been with us for the last few CMEs. He has been chairperson of our CMEs in the second and the third CMEs also. He is past president of API Gujarat and the present chairman of Gujarat State Chapter of IACM. Dr. S.N. Nagarajan sir, he is the vice chairman of Lipid Association of India. Narsingan sir, vice president of World Hypertension League. He's a proud recipient of the Master Teacher Award from API and ICP. We welcome you, sir, and are honored to have you with us. With these words, I now request our moderator, request Dr. Anil sir to welcome our moderator, Dr. Chandrasekhar sir.
Thank you, sir. It's my pleasure and it's an honor to introduce Dr. Chandrasekhar. At the outset, I would like to thank IACM team to arrange such excellent CMEs regularly, and it is an honor to be a part of it. So let me introduce Dr. Chandrasekhar Silvania. He is a professor, Stanley Government Medical College, Chennai, and he is an astute clinician and academician, as well as a great administrator. He had been a part of National Association of Physicians of India in various capacities, like he was a South Zone representative of Governing Council body, then he was a Governing Council member, then he was a member of ICP faculty, and he is also IACM Secretary of Tamil Nadu State, and he's a convener of IACM chapter there. And along with that, he has been a part of education setup. He had been a teacher and a member of Senate, and so on and so forth. So I will request my co-chairperson to introduce the speaker, Dr. Raman Puri sir.
Yeah, good evening, everyone. At the outset, I would like to thank Dr. Parikh for giving me this opportunity. And I must thank Dr. M P Singh, who contacted me over phone, fixed me for this job. And I'm also equally thankful to Dr. Suresh, who had come down to Chennai, and Dr. M P S Chawla. I am grateful to Dr. Pathak, who is the president, and Dr. Anil, chairman of the UP chapter, and my friend Dr. Chandrasekhar, the secretary of the Tamil Nadu State chapter. Don't mention others' name. It does not mean that they are not recognized. You are always there, and I think the IACM is now gaining much more importance in the recent past. I'm really happy that I was there as a part of a function which was held in Chennai for inaugurating the Tamil Nadu State chapter. Today, you have chosen a very good topic that is about the lipid management in India, the current trends in managing lipids. This talk is going to be delivered by none other than our own friend, the founder chairman of Lipid Association of India, Dr. Ramanpuri. Dr. Ramanpuri basically is an interventional cardiologist. He started getting a lot of interest in the field of lipidology way back 2012. Started this association, Lipid Association of India. In fact, we started coming out with a lot of consensus statement right from 2016, 17, 20, 23, and 24. And periodically it has been acknowledged not only at national level, even at the international level. And it is not surprising to see that our consensus statement shared by Dr. Amanpuri are getting published in the Journal of Clinical Lipidology, which is a prestigious journal in the United States. And I'm really happy that Dr. Ramanpuri, who is our founder chairman for the Lipid Association, is going to deliver this lecture, for which I am the co-chair for this particular program. Thank you very much, Dr. Parikh and others. Let me now request Dr. Ramanpuri to take over and conduct it and proceed with this lecture, please. Over to Dr. Ramanpuri. Sir, unmute yourself, sir. Dr. Ramanpuri, sir. Unmute, sir.
Are you able to see my slides?
Yes, sir, we are.
Okay. Thank you very much. First of all, I thank Dr. Parikh for giving me an opportunity to present two important topics, and also thank you, Dr. Narsingan, for your kind work. And I think whatever we have achieved in LAI so far is a great contribution of Dr. Narsingan to that. He is with me since 2012. Rather, he was the first person to whom I called that he should become member of LAI. And I was lucky that he agreed to that. So my first talk is that it's a very important talk that are we putting Indian ASCVD patients at higher risk, higher avoidable cardiovascular event if we follow American Soul European lipid guidelines. We all know that LDL cholesterol has a strong causal relation to ASCVD, and we have a strong scientific evidence to that. LDL cholesterol has been the target since 1988. Initially, it was less than 130 milligrams, and subsequently it came down to less than 100. And in 2004 ATP3 update, the optional target was less than 70 milligram. And since then, we are all following these LDL cholesterol target of 70 milligram even now. Despite ACC in 2013 abolished this target, and they recommended statin in some group of patients. These guidelines are excellent for Europe and for USA because there had been a significant decline in cardiovascular mortality in these two means in Europe and in USA. But despite following these guidelines for almost 3 decades, the CVD mortality, instead of going down, it has gone up by 41% from 1990 to 2015. So we took into consideration all these points, and we came out with our first consensus statement in 2016. This was after exhaustive 2 years of discussion, and we classified patients based upon ASCVD risk factor into 4 ASCVD risk category, and low risk group, moderate risk group, and high risk group. And those patients with low risk group, if they had lifetime risk of more than 30%, were reclassified as a moderate risk group, and low risk group patient with one or more non-conventional risk factor was also reclassified as moderate risk group, and moderate risk group, if they had some non-conventional risk factor, they were reclassified as a high risk group. Also included in high risk group was high risk features, and there were about 7 high risk features, which included diabetes with no or one major ASCVD risk factor or no target organ damage and CKD. And those patients with pre-existing ASCVD, those patients with diabetes with 2 or more ASCVD risk factors or evidence of target organ damage or familial homozygous hypercholesterolemia, they were included in very high risk group. In our consensus statement of 2016. We were the first association in the world to recommend LDL cholesterol less than 50 milligram. And we, as Dr. Narsingh knows, we had a really difficult time to convince our colleagues that this is the right target for patients with ASCVDs, especially in Indian population. This was based upon strong scientific evidence, very strong evidence, which included list of these studies which have shown. And 6 months after our recommendation, European guidelines were published, and they chose number 70 milligram for their patients with ASCVD. So they made our task very difficult to convince our colleague further for lowering LDL cholesterol to less than 50 milligram. But fortunately for us, in 2019, European guidelines also brought down LDL cholesterol less than 55 milligram in patients with ASCVD. And in 2020, we updated our ASCVD risk algorithm, practically same as 2016, except that there was metabolic syndrome and aortic pulse wave velocity was removed from the non-conventional risk factor, and we introduced 4 new non-conventional risk factors in 2020 algorithm. But most important, what we did, that we introduced new risk group, which was an extreme risk group, which was further divided into category A. Category A are those patients of coronary artery disease or ASCVD who had one or more features of high risk group, and category B were those patients of coronary artery disease and ASCVD who had one or more features of very high risk group. And the goal of LDL cholesterol in category A was less than 50 milligram. Optional goal was less than 30 milligram. In category B, the goal was less than equal to 30 milligram. This was again based upon our strong scientific evidence. One of the most important trials which we took into account was 4A trial, in which there was 28,000 patients with ASCVD, and in which the median LDL cholesterol achieved was less than 30 milligrams, and there was about 15% reduction in primary endpoint and 20% reduction in secondary endpoint. 2022 ACC expert consensus also brought down the LDL cholesterol target to less than 55 milligrams in those with multiple major ASCVD events or one major ASCVD event with multiple high-risk conditions. Now, question is that why do we need lower LDL cholesterol goal as compared to European and American? After this background, which I've already discussed with you. For that, you have to understand few important facts about coronary artery disease in India. We have high prevalence of ASCVD. We have high prevalence of premature ASCVD. We develop coronary artery disease 10 years earlier than other ethnic groups, and 25% of myocardial infarction occurring in patients are under the age of 40 years. And we have this coronary artery disease is very aggressive, and it is associated with loss of young lives. And about 50% of death in India related to coronary artery disease occur in individuals below the age of 50 years. This now other important facts which you have to now take it very seriously is that the LDL cholesterol in South Asian, we are part of South Asian, is 10 milligram lower than LDL cholesterol. This is based upon Inter-Heart study, which is a very large case control study, which was published in 2016. And another study which compared lipid profile of American versus Indian also showed that LDL cholesterol on average was 7 milligram less in Indian as compared to US population. And we had significantly lower HDL, we had significantly higher triglyceride and ApoB as compared to Americans. That is what we call as an atherogenic lipidemia. This is one of the most important UK biobank prospective cohort study in which baseline characteristics of European were compared with South Asian ancestry in UK. It was found that LDL cholesterol was 10 milligram, approximately 9 to 10 milligram lower in South Asian as compared to European. South Asians have significantly lower HDL, significantly higher triglycerides, significantly higher lipoprotein small a, significantly higher C-reactive protein. And also we had high prevalence of CKD, high prevalence of diabetes, and high prevalence of hypertension. Surprisingly, South Asians were having more South Asians, significantly higher proportion of South Asians were on statin, significantly higher population, South Asian population was taking anti-diabetic medicine. Remember, South Asians were taking 12.8% of them were taking anti-diabetic as compared to only 3.2% European, and significantly higher hypertensive drugs were taken by South Asian as compared to European. with this, you will think that the CV events will be less in South Asian. Unfortunately, we had twofold increase in AACD event for South Asian as compared to European. That's quite alarming that despite higher proportion taking statin and antihypertensive, anti-diabetic drugs, and lower LDL cholesterol, we had higher AACVD. So this is based upon this ACC in 2018, they have put South Asian ancestry as one of the risk enhancing factors, along with another factors like CKD, chronic inflammatory disease, metabolic syndrome. Now, what are the key points which is there to suggest that we should have lower LDL cholesterol target? Now, so the important points you should understand that despite South Asian having LDL cholesterol 8 to 10 milligram lower than their Western counterpart, they still have higher cardiovascular event. Higher non-HDL cholesterol in India, because non-HDL is total cholesterol minus HDL cholesterol, and we know that non-HDL cholesterol is lower in South Asians, results in increased LDL cholesterol to non-HDL cholesterol discordance. Increased triglyceride in India leads to increased remnant cholesterol. As you all know that remnant cholesterol is a atherogenic cholesterol component of triglyceride-rich lipoprotein. Increased ApoB results in increased circulating atherogenic particle. You should remember that each particle, atherogenic particle, carries only one ApoB. And as you know that we have higher triglyceride, we have higher small dense LDL particle, so there is increase in ApoB in circulation. There is increased lipoprotein A, which you know is associated with increased atherogenicity. And despite significantly more South Asians taking statin, anti-diabetic, and antihypertensive drugs, they still have twofold increase in cardiovascular event. Given the high prevalence of CAD, increased prevalence of premature coronary artery disease, and aggressive coronary artery disease with increased associated mortality, India need to be treated more aggressively with low lipid-lowering drug, which means lower LDL cholesterol. With this is almost a summary which I have shown you. Now I'll tell you why these are important points. This is basically a summary that why we should have a lower LDL cholesterol target. To understand that, you know that this slide is seen by a majority of you many times, that higher the LDL cholesterol value, higher is the cardiovascular event. Cholesterol treatment trialist collaborator gave us some important facts about LDL cholesterol and event. If I reduce LDL cholesterol by 40 milligram, I reduce event by 21%. If I reduce LDL cholesterol by 20 milligram, I reduce event by 16%. If I reduce LDL cholesterol by 60 milligram, I reduce cardiovascular event by about 33%. These are relative risk reduction, not an absolute risk reduction. Now, less than 20, if I reduce LDL cholesterol by 10 milligram, based upon Mendelian randomized studies, I reduce events by 18%. Why it is greater than 20%? Because all these loss of function mutations are, associated with lifelong decrease in LDL cholesterol. So there is a longer, lower LDL cholesterol, which will reflect in a greater reduction in event. And if I reduce LDL cholesterol by about 10 milligram, about 5 milligram, it reduces even by 8 to 10, percent. Remember, 1 milligram LDL cholesterol reduction, if reduced in early in life, will reduce event by 0.5 to 1%. So how important is even 1 milligram of LDL cholesterol reduction important? So why these facts are important? Now, for example, we all know South Asian have approximately 8 to 10 milligram lower LDL cholesterol as compared to European. I have given you enough evidence for that. So this means to achieve the same percentage reduction in CV events, Indian patient LDL cholesterol must be 8 to 10 milligram lower than the Western population to have the same event. So if 40 per milligram reduction, 21% reduction, so our LDL cholesterol should be 8 to 10 milligram lower than the Western patients. If we don't do it, this means there will be greater major adverse cardiovascular event in South Asian if we follow European LDL cholesterol goals. This is one of the most important points which made us to think that the LDL cholesterol goal in Indian population should be lower. Now coming to non-HDL cholesterol, at any level of LDL cholesterol, higher non-HDL cholesterol, as shown in yellow bar, is associated with higher events. And this is a very important meta-analysis of 8 statin trial in which those patients who had LDL cholesterol less than 100 milligram and non-HDL cholesterol more than 130 milligram, they had 32% risk, higher risk of events as compared to another group of patients who had LDL cholesterol more than 100 and non-HDL cholesterol less than 130 milligram, where there was only 2% increase in cardiovascular events. So you can understand how important is non-HDL cholesterol, and it has to be important because non-HDL cholesterol carries all circulating atherogenic cholesterol component, which of course included LDL cholesterol also. So that is the total atherogenic cholesterol is what is non-HDL cholesterol. This is an Indian study in diabetes patients. It was seen that those patients, diabetic patients who achieved LDL cholesterol less than 100 milligram and who had triglyceride more than 150 milligram, 38% of these patients had non-HDL more than 130 milligram. This means there was a higher discordance between LDL cholesterol and non-HDL cholesterol as the triglyceride level goes up. So what we can do is that we have to bring down non-HDL cholesterol to the target. Therefore, we have to treat these patients more aggressively, and we have to bring down LDL cholesterol to a lower value. Now, coming to ApoB, as I said, that each atherogenic particle carries one ApoB. So if I know the number of ApoB, so I'll be able to understand how many circulating atherogenic particles are there in the circulation. And remember, it is ApoB which is, marker of atherosclerosis, because once it goes into the subintimal space, it will be which initiate the process of atherosclerosis. Inter-heart study shows that ApoB to ApoA ratio, higher the ApoB to ApoA ratio, there is higher in cardiovascular event. As inter-heart study also shows that South Asians have more ApoB and ApoB ratio as compared to other community. This is a study which is a very important meta-analysis. For example, if I take non-HDL cholesterol as a primary endpoint, then as compared to LDL cholesterol as a primary strategy, I'll be able to prevent 300,000 more events if I take non-HDL cholesterol as a target, not LDL cholesterol as a target, and non-HDL cholesterol as a target. If I take ApoB as a target, I will prevent 800,000 more events as compared to LDL cholesterol target, and about 500,000 more events as compared to non-HDL cholesterol as a target. This means ApoB is a better predictor of cardiovascular event as compared to non-HDL cholesterol, and non-HDL cholesterol is a better predictor of cardiovascular event as compared to LDL cholesterol. And what exactly we want? Low ApoB, low LDL cholesterol, and non-HDL cholesterol to have the maximum benefit. Unfortunately, when you treat a patient with statin, you lower LDL cholesterol much more than what you lower when ApoB is lowered. And this difference is somewhere around 15%. Rather, what I want to say is that with statin, the discordance between LDL cholesterol and ApoB increases. Remember, our objective is very clear. We have to bring down LDL goal, we have to achieve LDL cholesterol goal, we have to achieve non-HDL cholesterol goal, and we have to achieve ApoB goal in order to reduce the residual risk which remains in the patients despite achieving LDL cholesterol goal. Another important, lipoprotein which you should not miss is that lipoprotein small a, 25% of Indian population have increased lipoprotein small a. Rather, if it is more than 50 milligram, according to LAI, it is a high-risk feature. And we all know that lipoprotein A is highly atherogenic, pro-inflammatory, and thrombogenicity is more. At present, we have no treatment to bring down lipoprotein small a. We are expecting some drugs which will reduce lipoprotein A by 80 to 90%. But at present, the strategy to reduce atherogenicity of lipoprotein A is just by reducing LDL cholesterol to a much lower value. This is comparison of ACC guidelines, European guidelines, LA guidelines, and NLA scientific statement. We, as you can see, we do not have similarity between LA guidelines and ACC guidelines, LA guidelines by European guidelines. We are more aggressive, and we have to be more aggressive because we have more premature coronary artery disease. We have more aggressive coronary artery disease. And therefore, I summarize with the same slide which I have shown that we have to bring down LDL cholesterol to a lower value so as to reduce the cardiovascular mortality and morbidity in Indian population. Thank you very much for your kind attention.
M P Singh, are you there or not?
Hello.
I would now request Dr. Chandrasekhar to take the meeting forward and see if any questions are there right now or after the second lecture.
So we can have the questions after the second lecture, or shall we have it now, sir?
Chandrasekhar, I think you can take them later on once the talks are concluded.
Yes, sir. Yes, sir.
So let's start with the second lecture.
Yeah. Did you see the slides? So now I'll discuss about Consensus 4, which was published about 2 months before in Journal of Clinical Lipidology. So I've already discussed about our Consensus 1 and Consensus 3. This is basically a continuation of Consensus 3. Now, what was the need for Consensus 4? You'll say that why you have come out with Consensus 4. There is evidence of newer risk modifier and or high risk conditions having a strong association with ASCVD or incremental value over the other non-risk factors. There is enough evidence from RCTs of a linear relationship between LDL cholesterol lowering, decrease in percent atheroma volume, and major adverse cardiovascular event reduction. Means lower the LDL cholesterol level, greater is the percent atheroma volume reduction, and lower are major adverse cardiovascular event. Newer studies have shown that extremely low LDL cholesterol, 10 to 15 milligram per deciliter, results in benefit in cardiovascular event reduction without any significant adverse effects. There is enough evidence that lowering inflammation, metabolic residual risk, and thrombotic risk has additional benefit in cardiovascular event reduction, thus beneficial in those with recurrent cardiovascular event despite achieving LDL-C, non-HDL-C, and ApoB to the targets. This was our publication in Journal of Clinical Lipidology. Now I have talked about algorithms. You know about calculator, but there are some limitation of this algorithm and calculator. The major limitation of this algorithm is that they estimate the probability of developing ASCVD based on risk factors, traditional risk factors, measured at a given point of time, but it cannot accurately identify specific individual who will develop this disease. So if 100 patients are there, if 10 patients are going to have an event, we are not able to define these, we are not able to pick up these 10 patients who are going to have the events. That is the major limitation of these algorithm or risk calculator. Based upon these traditional risk factors, we are able to predict only 50 to 60% of cardiac risk. So this means another 50%, goes undetected. This has been, proved in various trials, because in this meta-analysis of 4 studies, those patients who had an MI, 68% of them had less than 50% of stenosis. And in another study, only 70% of patients who are in low risk group had myocardial infarction. This young first acute myocardial infarction in young population. So there is a missing link, based upon this factor and the clinically evident CVD. So there is a missing link. And this missing link is responsible for loss of some of the important lives, which include some of our young doctors who died at the age of 29 years. And so that is what we have to look for. And the basic missing link is subclinical atherosclerosis. What we do in primary prevention is based upon risk factors like hypertension, diabetes, smoking, all that. We treat that patients. And we treat all patients with these risk factors. And some of these patients eventually had an event. And when they have an event, we know that this patient has coronary artery disease and we treat accordingly. By that time, it is too late because some of loss is already there. So our objective is very clear that if we pick this subclinical atherosclerosis earlier than it manifests, then we can be more aggressive in treatment so as to prevent the plaque progression, or we will like to achieve plaque regression, especially in Indian population. Therefore, these patients, we can prevent cardiovascular event in future. So the primary prevention is restricted to a very small area of preventing atherosclerosis based upon risk factor assessment. The question comes that how we'll assess this subclinical atherosclerosis, how we should do it, and when should we do that? So one of the most validated and most studied is carotid and femoral artery plaques. This is a very important study, cave study, in which 13,000 low-risk, healthy, asymptomatic individuals who did not have diabetes or CVD, the 10,000 patients were followed for 10 years. It was found that those patients, even those patients in which the femoral or carotid plaque was less than 50%, they had about 40% event. And of course, the event went up to 80% when the stenosis was more than 50%. That shows that even non-obstructive or non-significant non-stenotic plaque is also leads to a higher event if they are not treated adequately once they are picked up. This is another Turkish study in which it was seen that the femoral plaque, only femoral plaque with surface irregularity, had hazard ratio almost similar to those of coronary artery calcification without evidence of carotid or femoral atherosclerosis. Though we have number of studies, but keeping it restricted to only 2 studies, what LII has suggested that any person who has an evidence of femoral or carotid plaque, whether it's an obstructive or non-obstructive, should be placed in very high risk group, and the LDL cholesterol target should be less than 50 milligram in these patients. And this we differ from European guidelines, whereas European guidelines says the plaque if present is a risk modifier in individual with lower moderate risk group. We differ from them almost to the other extreme. Then second is coronary artery calcium score, which we call as CAC score, using CT scan. Presence of calcium in coronary artery is almost exclusively results from coronary atherosclerosis if you exclude CKD or primary hyperparathyroidism. And total coronary artery calcium score means greater the coronary artery calcium score means greater is the coronary atherosclerotic burden or plaque burden, means which leads to increased risk of future cardiovascular event. So, but remember one thing, higher calcium score doesn't mean that patient has an obstructive coronary artery disease. You can have high calcium score with almost non-obstructive coronary artery disease. The advantage of coronary calcium score is in this study that if we go for coronary calcium score in intermediate risk group or moderate risk group, these moderate risk groups are reclassified in 14% as in a high risk group and in 63% in low risk group. Coronary calcium score is a tip of an iceberg. It just tells you that there is an atherosclerosis in that particular area of the coronary artery. But it doesn't tell you that how much is the atheroma, how much is the plaque burden, how much is the necrotic core, how much is the lipid core, how much is the fibrous cap thickness. So it doesn't tell you whether the plaque is vulnerable or non-vulnerable, which of you can find out only with intravascular ultrasound or by CT coronary angiography. Now, what are the studies which shows that coronary artery calcium score has relations to cardiovascular event? MESA study was the most important first study. The mean age was 62. It was found that as compared to calcium score 0, if the calcium score is between 1 to 100, the risk of non-fatal MI and CSD death increases by 4.5 times. When it is between 100 to 300, it goes up by 10 times. And if it is more than 300, it goes up by about 14 to 15%. Not only this, only if the calcium score is between 1 to 10, very small number of calcium score also has 3 times higher risk of cardiovascular event. So that shows the importance of getting calcium score in your patient, especially with multiple risk factors. That will tell you whether there is underlying atheroma or not. Then there was a cardiac study in which young people were recruited to see the prevalence of coronary artery disease and CSD. The mean age was 40. It was found that 10% of those who are just 40 years of age had calcium score of more than 0. And any calcium score was associated with 5 times CSP and 3 times CVD. And those who had a calcium score of more than 100, they had absolute mortality rate of 22.4%. Increase in calcium score is associated with decreased survival. This is based upon study of 11 years in 45,000 patients with an average of 56 years. Now, if the calcium score is 0, it is said that it gives you 15 years warranty. Warranty means that the events are going to be very less. And this is the confirmed registry. This shows that in 10.8 years, those patients who had calcium score of 0, they had the event even less than those patients who did not have any risk factors. The risk was somewhere around a 2% cumulative mortality rate. So very low risk was there when the calcium score was 0. Remember one thing very clearly, the absence of calcium score doesn't mean that patient doesn't have atherosclerosis. In one of the Scott heart study, it was found that those patients who had myocardial infarction, 10% of these patients has calcium score 0. So calcium score present justifies that there is an atheroma, but absence of calcium score doesn't rule out atheroma. So you have to take into consideration various other risk factors which can result in atherosclerosis. Now question comes at what age the calcium score 0 become more than 0. So based upon number of studies, it has been found that in man, the age is 42 and in woman it is 58. The age will become younger, less depending upon number of risk factors present, like family history of CSP, smoking, dyslipidemia, and hypertension. So calcium score will appear more at a younger age in this group of patients, which can be 6 to 7 years or 7 to 8 years earlier than 42 years. Now, what are the indications for looking for subclinical atherosclerosis is that individuals who are considered to be in moderate risk and high risk group as per LAI risk algorithm. For example, if somebody has 3 or more ASCVD risk factor, his TMT is normal, everything is fine, then this patient can be subjected to CT coronary for calcium score. And if calcium score is present, then patient can be reclassified as a high risk group. Those with family history of premature ASCVD or uncertain family history, suspected or diagnosed familial hypercholesterolemia, individual with multiple ASCVD risk factor, individual who are reluctant to take statin or who are intolerant to statin. Unfortunately, again, we differ from European guidelines. European guidelines consider coronary calcium score as a risk modifier for low or moderate risk group of patients. ACC is a bit more aggressive. They have recommended moderate to high intensity statin in those patients with coronary calcium score of between 1 to 99 or less than 75th percentile. They recommended ezetimibe in those with the calcium score of 100 to 99 or more than 75th percentile if the LDL cholesterol is more than 70 milligram despite statin. And if they have advised PCSK9 inhibitor in those with calcium score of more than 1000 who have an LDL cholesterol more than 70 milligram despite statin and ezetimibe. Whereas LAI has given a very simple algorithm that if calcium score is 0, you risk stratify patients based upon LAI ASCVD risk algorithm and fix the target and try to achieve that target. Those patients with calcium score of 1 to 99 and less than 75 percentile for age and gender is considered as high risk group with LDL cholesterol target of less than 70 milligram. Those who have calcium score of 1 to 99 and more than 75th percentile for the age and gender, or those who have a calcium score of 100 to 299, they are classified as a very high risk group with LDL cholesterol less than 50 milligram. And those with calcium score of 300 or more, they are in extreme risk group category A with the LDL cholesterol target of less than 50 milligram and optional goal of less than 30 milligram per deciliter. And of course, one very simple method of screening for peripheral artery disease is looking for ankle brachial index. And you take the systolic blood pressure at brachial systolic pressure and ankle. And if the ratio is less than 0.9, that shows a significant obstructive peripheral artery disease. Unfortunately, ACC says ABI less than 0.9 as a risk enhancer. Since 2016, LAI has stated that presence of ABI of less than 0.9 is a manifestation of ASCVD, and the LDL cholesterol target in this patient should be less than 50 milligram. Now, why we are aggressive? In my previous talk, I have said that we have aggressive coronary artery disease, we have more premature coronary artery disease. So it is important for us to bring down LDL cholesterol at an early age. Remember, if I reduce LDL cholesterol by 40 milligram early in the life, I reduce even by 55% in later life, part of life. And to achieve the same 55% in later in life, I have to bring down LDL cholesterol by 120 milligram. So it is better to lower LDL cholesterol slightly in a younger age so as to have a greater benefit at a later age. And we all know, based upon lot of trials now in which LDL cholesterol has been brought down to a very low level, like LAPCO trial where LDL cholesterol achieved was 30 milligram, that there is no J-shaped curve which you see in hypertension and diabetes. There is no such J-shaped curve with LDL cholesterol lowering an event. So there is an event reduction even as low as less than 10 milligram of LDL cholesterol, and greater is the LDL cholesterol, greater is the reduction in percent of trauma volume. Statin is a very therapy is very easily accessible, is inexpensive in India. So there is a need to pick up early subclinical atherosclerosis in India and bring down the LDL cholesterol less than 50 milligram with an objective of not stabilizing the plaque, but our objective is that plaque should be regressed. Now coming to the main algorithm, which was you have seen of 2020. Now I'm showing you the main algorithm. It is almost same as 2022. Whatever is shown in black and white is whatever was there in 2020. There has been major change in major ASCVD risk factor. We have shifted family history of premature ASCVD to the high risk feature. Also included in high risk features are apolipoprotein B of more than 130 milligram, metabolic syndrome, non-alcoholic fatty liver disease with fibrosis grade 2 or grade 3, and coronary calcium score asset. If any one of these high risk feature is present, the patient will be classified as high risk group. If two or more of these high risk feature will be present, then patient will be classified in a very high risk. The non-conventional risk factor name has been changed to risk modifier. Plasma triglyceride of more than 150 milligram fasting or non-fasting of more than 75 is included as a risk modifier. Also inflammatory joint disease, women-related problems like premature menopause, high polygenic risk score, air pollution, and HIV infection. Now, important thing which we have included this time, that LDL cholesterol and non-LDL cholesterol is no more, they are no more the only LDL cholesterol target, but they are risk factors. Now, what is that? If LDL cholesterol is between 100 to 129 and non-LDL cholesterol is between 130 to 59, the patient will be classified in the low risk group. If the LDL cholesterol is between 130 to 159 or non-LDL cholesterol is between 160 to 189, the person will be classified in moderate risk group. If the LDL cholesterol is between 160 to 189 milligram or non-LDL cholesterol of 190 to 190, 19 milligram, the patient will be classified as the high risk group. Also, if there is one high risk feature, if there are two or more high risk features, the patient is classified as a very high risk group. LDL cholesterol more than equal to 190 milligram or heterozygous FH with any LDL cholesterol value will be classified as very high risk group with LDL cholesterol target of less than 50. Established ASCVD, whether obstructive or non-obstructive, or calcium score between 100 to 299 or more than 75th percentile in coronary if calcium score is between 1 to 99. They all these features, they are included in very high risk group. Now category A are in those whatever was there in the initial 2020 algorithm, but now we have added coronary calcium score more than equal to 300 or patients of homozygous FH without ASCVD, whereas in category homozygous FH with ASCVD is included. This time we introduce another category, which is category C. Now, what is this category C? There are in 4-year trial in which the median LDL cholesterol achieved was 30 milligram, 15.5% of these patients had even with achieved LDL cholesterol of 50 milligram. Remember, these patients had 5 or more risk indicators. You can see on the left side, there are about 10 risk indicators like heart failure, hypertension, diabetes, stroke, CVD. In those patients who had an event, they had 5 or more of this risk indicator. So these are the patients where we have recommended LDL cholesterol goal of 10 to 15 milligram and non-LDL cholesterol goal of 40 to 45. And to make diagnosis of extreme risk of ADC is you have to have a very strict criteria. These are the patients who gets cardiovascular event despite LDL cholesterol around 30 milligram per deciliter, despite revascularization as indicated, aggressive lifestyle management, effective control of all the modifiable risk factors, and addition of SGLT2 inhibitor or GLP-1 receptor agonist for metabolic residual risk, icosapent if there is elevated triglyceride, colchicine if high sensitive CRP is more than 2, dual antiplatelet or aspirin with low dose rivaroxaban for residual thrombotic risk. If following all these things, a patient continues to have cardiovascular event, then one should consider, we are not recommending, we are saying consider further lowering of LDL cholesterol to around 10 to 15 milligram per deciliter. Now, I'll run through. NAFLD is considered as a high-risk features, and LDL cholesterol recommended is less than 70 milligram. Metabolic syndrome is also, considered as a high-risk feature with LDL cholesterol of less than 70 milligram. Inflammatory joint disease is also a risk modifier. In one of the largest studies, it was found that rheumatoid arthritis had same incidence of myocardial infarction as diabetes had. And the only thing which I want to highlight that during acute phase, never go for lipid profile assessment because they will underestimate total cholesterol, LDL cholesterol, HDL cholesterol, and TG. Always go for lipid assessment after 2 to 4 months of starting anti-inflammatory treatment. Now, pregnancy-related issues are very important. Those who it has been seen in a study of 146,000 women with first pregnancy that hypertension associated during pregnancy was associated with 2.2 times higher risk of subsequent cardiovascular event. Gestational diabetes, there is 63% odd ratio for CVD. Premature menopause, there is 50% increase in CHP risk, 23% increase in stroke risk, 12% increase in all-cause mortality, and 19% increase in cardiovascular mortality. Therefore, the ACC has put these premature menopause and preeclampsia as risk and answer factor in their guidelines. Genetic risk, we all know that single gene mutation like homozygous FH or heterozygous FH is associated with higher cardiovascular events, whereas there are in polygenic risk score, there are multiple gene variants. They have individually they have small impact on cardiovascular risk, but if they are taken in totality, they have almost the same impact as monogenic risk of single gene mutation. If we find this polygenic source, we know that this patient is going to have a future cardiovascular event. We can, go for aggressive lifestyle management in early age so as to prevent cardiovascular event in near future. Indians with high polygenic risk score has 3.22-fold higher risk of coronary artery disease. Right now, we have polygenic risk score, which is based upon European ancestry, which was taken from UK Biobank. But I think we will shortly have some this from Indian and South Asian ancestry also. Air pollution, the city we are living in India, like Dr. Chawla is also with me in Delhi only. So we are very prone to have myocardial infarction and ISD related mortality, hypertension, and diabetes. Right now, we have put it in risk modifier, but eventually this will become a high risk feature. Probably in our 3 years, update of consensus statement, this will be a high risk conditions. Extreme of single risk factor, LDL cholesterol of more than 160 milligram, regular smoking of more than 1 packet of cigarette per day, BP of 180 or 110 millimeter more than that, and family history of premature coronary artery disease. They are all of extreme single risk factor. If in any one of them is present, you can be very aggressive and try to bring down LDL cholesterol to less than 70 milligram. These are our target, and primary target is LDL cholesterol, co-primary target is non-HDL cholesterol, and secondary target is ApoB. This is our, the conclusion is that key component of treatment is lifestyle intervention, make sure there are no secondary dyslipidemia, and treat all modifiable risk factors, treat all residual risk factors, especially in very high risk group and extreme risk group. The rest, I think I've discussed already in detail. Thank you very much for your kind attention.
Thank you, Dr. Ramanpuri, for your wonderful lecture. You brought a lot of the useful information to all of us. You nicely alluded to the challenges and the alarming statistics that are unique to India of course, they are all major concern, and immediately the LIA stepped into action and took some appropriate efforts to frame a guidelines. So we are proud that yourself and Dr. S. N. Narsingan are part of these guidelines framing, and we are happy to have you with us. And of course, these guidelines will help particularly the Indian patients to screen, identify, and categorize, and of course, to treat. I think it's a wonderful lecture. You nicely alluded to the newer, apart from what is the need to look beyond LDL, like so you nicely mentioned about the novel risk factors and so on. Before I go on to the chat box for the questions and to get other expert comments, may I now invite Dr. S. N. Narsingan to comment, please.
I think we had an excellent exposition of the subject, elaborated in an elaborate manner. I think we have understood the need for separate consensus statement for treating Indian patients with the dyslipidemia, and how the European Society guidelines as well as the AAC guidelines probably may not be really useful for our country. And that is the first session what he had covered. Subsequently, he started showing us a lot of information with respect to the newer risk factors, risk enhancers, starting from the calcium score and NAFLD, rheumatoid arthritis. So many things he had brought in. And all these are very important in increasing the risk of cardiovascular disease. How best is to identify these problems and how best we can probably bring down the LDL cholesterol. Apart from bringing down the LDL cholesterol, he also mentioned that we need to concentrate on the pro-inflammatory factors like high-sensitive CRP. It is routinely now being prescribed by many cardiologists that the colchicine plays an important role. 0.5 milligram of colchicine is given as an anti-inflammatory drug along with the drugs. In addition, he also had given a prescription for using some acetyl salicylic acid in certain situations. In addition, even anticoagulants also he had mentioned. Of course, there is always a place for SGLT2 inhibitors as well as GLP-1 receptor agonists in the management of patients in whom you have a higher risk. These are the things what he had again highlighted. I think all of us had an opportunity to listen to Dr. Raman Puri. I'm sure there will be many doubts. I think you can probably raise the questions now. We'll be in a position to get an answer from Dr. Raman Puri, please.
Yes,
There are
Dr.
some
Puri, I
questions.
want to ask one question. May I allowed?
Yeah,
Yeah,
please.
please go ahead.
Yeah, Dr. Puri, one thing, anything special for to prevent the plaque rupture, number one, and number two, any specific treatment for FOB and LPA?
Now, see, there are for plaque rupture or plaque, there are three important plaque characteristics. One is the plaque fibrous cap thickness, how thick it is. If it is less than 65 microns, there is a greater probability of its rupture. Second is how much is the plaque burden. If it is more than 70%, it is more vulnerable. And third, of course, is the minimal luminal diameter of the vessel. If it is more than 4 millimeters there, then it is these are the three important. If all these three are present, the chances of having acute coronary syndrome due to this unstable plaque is almost 19 times more than if it is not present there. Now, the question is that if once you diagnose, plaque by either ultrasound, femoral ultrasound, or by carotid ultrasound, then the best thing is that you bring down LDL cholesterol to a lower level as we have recommended. Why we have said 50 milligram, that in 50 milligram LDL cholesterol, practically all plaque, they stabilizes, their fibrous cap thickness increases. We have now data from cities. One of the studies, an ESCORT study, in which it was found that if you give pitavastatin 4 milligram, the patient is admitted with acute coronary syndrome. And if I repeat OCT after 3 weeks, there is a significant increase in fibrous cap thickness. You can understand very well if the covering is thick, the chances of its rupture or erosion will become very less. Therefore, aggressive LDL cholesterol lowering and maintaining that lower LDL cholesterol for a longer time is a prerequisite, is one of the most important steps towards stabilizing the plaque and to prevent the plaque erosion. That is number one. which you should very clearly understand. Of course, you have to treat all modifiable risk factors. You have to treat hypertension, blood pressure. We cannot only look at the plaque. There are other multiple, contributors to, plaque instability. So that is one. What was your second question?
LPA and FOB.
Now, ApoB have already said that each atherogenic particle in circulation, whether it is VLDL, IDL, DL, whatever it may, carries one ApoB. So, number of circulating ApoB gives you an indirect evidence of how much is the circulating atherogenic particle. The treatment strategy for non-LDL cholesterol, non-LDL cholesterol, and ApoB is same. You have to aggressively bring down LDL cholesterol, because 80 to 85% of ApoB is due to LDL cholesterol particles. So if you bring down LDL cholesterol, the LDL will come down, LDL will come down, and ApoB will come down. What I have highlighted in my first talk is that you have to make the concordance between LDL targets, non-LDL cholesterol target, and ApoB. Now, for example, if the LDL cholesterol is less than 50, the non-LDL cholesterol is 60, and ApoE is 50. So we have to bring down these targets to this level to have the maximum benefit in CV event reduction. Therefore, we have to be very aggressive in controlling LDL cholesterol volume, and that is what LDL cholesterol level, because you bring down LDL cholesterol, non-LDL cholesterol will come down and ApoB will come down. Unfortunately, with statin, LPA will go up. It is the only drug which increases lipoprotein small a by about 5 to 10%. So there is, so far, based upon epidemiological study, Mendelian randomization study, and other studies, population studies for heart study, you have shown link of LDL lipoprotein A versus coronary artery disease. Means higher lipoprotein A, higher is cardiovascular. So far, we have no evidence based at present that if I lower lipoprotein small a without changing LDL and non-LDL cholesterol, it is going to result in reduction in cardiovascular event. We are waiting for Horizon trial results, which will be published shortly, in which the lipoprotein has been brought down by antisense agent, small
Niacin.
Again, and that will show us whether lowering lipoprotein A will translate into reduction in cardiovascular event. So right now, if LPA is raised, then you have to bring down LDL cholesterol to a lower value to just neutralize the atherogenicity contributed by lipoprotein A. You have to reduce it, counter it by reducing LDL cholesterol level at present. This is the at present, and second most important thing is that, see, if you measure LDL cholesterol, 30% of its component is from the cholesterol content of lipoprotein A. So whatever is the lipoprotein part, we say 100 milligram of lipoprotein A. So 30 milligram of the cholesterol component of this lipoprotein A will contribute to the LDL cholesterol which you are measuring. So when you are reducing LDL cholesterol, which you can say the corrected LDL cholesterol value may not come down, because it will come down, but the total LDL cholesterol value will not come down because you are not going to change lipoprotein A cholesterol component. So now whether it is going to reduce cardiovascular event in future, I don't know. Let us wait for these trial results.
So Dr. Puri, in high-risk patient, every patient should have a intravascular ultrasound, intracoronary ultrasound to assess the plaque level?
No, not at all. Not at all, because we know now, for example, we have Glasgow trial, we have Pacman AM trial, we have Huygens trial, we have Avopac trials. We have number of trials with us now that shows that if you lower LDL cholesterol, there is a stabilization of plaque, there is a reduction in percent atheroma volume. Now in Glasgow trial, when the mean LDL cholesterol was brought down to 30 milligram, there was 1% reduction in percent atheroma volume. Remember, 1% reduction in percent atheroma volume translated to 20% reduction in major adverse cardiovascular event. If you look into the Huygens trial, there was 2.5% reduction in percent atheroma volume with achieved LDL cholesterol of 28 milligrams. So we have enough data from these intravascular studies that aggressive LDL cholesterol lowering will not only stabilize the plaque, make the fibrous cap thickness, increase in fibrous cap thickness, it will decrease lipid core burden index, which we call a LBI, which is detected by near infrared spectroscopy, but it will also reduce percent atheroma volume, which will subsequently result in reduction in cardiovascular event. So I think we should go for aggressive LDL cholesterol lowering, like in acute coronary syndrome. LAI recommendation is that we recommended for the first time, we were the first association in the world to we recommended that as soon as patient is admitted with acute coronary syndrome, you start high intensity statin plus ezetimibe in emergency trials when you are giving dual antiplatelet therapy, and send lipid profile assessment at the same time in emergency mode. Number two, once you get the lipid profile report, you know that in which ASCVD disease category that patient belongs to and what should be the LDL cholesterol target. So you will know that what percentage of LDL cholesterol reduction you require. So if you think that with high intensity statin and ezetimibe, you can achieve that LDL cholesterol target, continue same dose. If you require additional 20% LDL cholesterol lowering, you add bempedoic acid. If you require more than 20% LDL cholesterol reduction, you add PCSK9 inhibitor. Repeat lipid profile after 2 weeks time. If you have achieved the target, continue same treatment. If the target is not achieved, you can add more lipid lowering drug. Objective is very clear that you should achieve LDL cholesterol target by 4 weeks time in patient with acute coronary syndrome, and 12 weeks time in patient with stable coronary, or chronic coronary syndrome. So this is what is our target, which are very, very clearly shown. We have highlighted in our recommendations.
Thank you, Dr.
Yes, sir.
Polish.
So
Thank
there
you,
are
sir.
some queries also, sir. Like Dr. Das Munshi wants to know. So we have excellent LA guidelines. Like, what are all the things? Like, there must be some kind of RCTs or some kind of the trials should have been done in Indian population, should have been considered to make these guidelines to formulate. So can you elaborate on those guidelines, sir? Like, what are all the RCTs or meta-analyses based on which these LA guidelines are particularly in Indian population?
Chandrasekhar, the biggest limitation in our country is lack of RCTs from our country. Why it is like this, we don't know, but now LAI has, in 2024, we are planning number of, studies from India. Now, for example, we are study from India, original study from India of using triple lipid lowering drug, means 40 milligram of rosuvastatin plus 10 milligram of ezetimibe plus 180 milligram of bempedoic acid given in acute coronary syndrome in emergency trials is already sent for publication. And I think it will be published probably this month or next month in Journal of Clinical Hepatology. This is the first study from India. No other country has done such similar study so far. So that is what we are going to have now. And based upon this study, I can say that we have clearly shown that there is a significant reduction in LDL cholesterol, and 60% of our patients achieved LDL cholesterol of less than 50 milligram in just first week. The first week we achieved LDL cholesterol of less than 50 milligram, and it translated into reduction in cardiovascular event. Now, what is that? We have data of about 80 patients who have now completed 1 year of follow-up. Now we have hardly any mortality, 2 mortality out of these patients who in 1 year's time. Remember, if you look into the past data, which shows that there in 1 year's time you have mortality of somewhere around 10 to 15%. 2% is hardly any mortality, So now we are in a process of coming out with our own data. This has been a biggest data. And second is that whatever LDL RCTs are there, a relationship of LDL cholesterol to coronary events are undisputed. Whether you do in Indian population or do in Americans or European, it's not going to change. You have strong epidemiological data from India. We have utilized these strong epidemiological data from India and then try to, use this epidemiological data with RCTs of the Western and European world and try to come out with guidelines. Like, for example, high incidence of prevalence of coronary artery disease, high prevalence of premature coronary artery disease, malignant course of coronary artery disease, getting coronary artery disease with 10 milligram lower LDL cholesterol. These are data from India also. We have got data from like ICR in that study shows that in 4 states in India, the mean LDL cholesterol was 94 milligrams.
Almost to the tune of 82%, we have dyslipidemia in India, sir.
So having a large RCTs like what we have Fourier trial or Odyssey trial, it is a time consuming. I think it will be, if not now, of course, we are going to have these RCTs in near future. I think Dr. Narasimhan would like to say something.
No, I think you have given a lot of explanations about the need for coming out with these guidelines. Of course, Chandrasekhar and other people who are on the screen must know that it is only the expert consensus statement and not the guidelines. We need to be very careful in using the terminology guidelines. The guidelines are not the guidelines that have been framed by Indian people. Here is only the consensus statement, because we actually, what he has already explained about the epidemiological data, what is available in plenty in our country, had been taken into consideration for formulating the so-called consensus statement. And of course, with the evidence that is available from other countries, they are also taken into consideration compared with our own people. And then people are coming out with this sort of consensus statement. That is the basic information what I thought I should share it with you, number one. Number two, with regard to lipoprotein Dr. Raman Puri was kind enough to tell us recent advances, what is happening in the field of a therapy for LPA. Recently, the people have now completed the phase 2 study of Pelacarsen. Pelacarsen is a new drug which is probably going to hit the market with probably a good advantage in reducing the lipoprotein. Present, there are few studies which started showing about the efficacy of acetylsalicylic acid aspirin in those patients with elevated LPA levels. In case you have an elevated LPA levels, if there is a strong family history of coronary artery disease, if there is a premature coronary artery disease, all that you should do at this time, as per the recommendation by Lipid Association of India, is to bring down the LDL all the time. In case the patient is going for a recurrence of events, you can probably try to use the drugs like PCSK9 inhibitor, though there is no indication at this stage. The second point, what I thought I should tell you. Now that Dr. M P Singh has been the coordinator for this evening meeting, he introduced himself as a neurologist to me when he was talking to me. I think probably M P Singh will be tempted to ask Dr. Manpuri with regard to the usage of high-dose statin in people with ischemic stroke, and where exactly you will place this molecule in lacunar stroke.
Yeah, sir, I was wanting to ask, is there any level beyond which you think the risk of hemorrhagic stroke increases? Whether there have been randomized control trials or meta-analysis up to 55 milligram per deciliter, but is there any level below 30 in which the risk of hemorrhagic stroke has increased?
I think it's a very important point which is asked from me in most of the platform. See, there is no lower level of LDL cholesterol where there is increase in risk of intracranial hemorrhage or intercerebral hemorrhage. See, if you look into the Fourier open label extension study, because this is a study in which the mean LDL cholesterol was 28 milligram and the patient was followed up for 7 years, there was no significant increase in intracranial hemorrhage. There was no significant increase, neither in cognitive function or there was an increase in the bleed. So,
I repeat, this is the changing announcement. Mr. Prasanna Rantu, I repeat, Mr. Pathak.
I think they should mute all others except Raman Puri, please.
Mr. Prasanna Rantu, we are requested to
disturbance
yeah. So, see, the only thing which I want to say that, like we classify patients of coronary artery disease into various IACM risk category. Similarly, patient of stroke also, you stratify patients into various risk category. Though we have only 2 studies, one is treat to target, and second study name is. We have Sparkle trial. There are 2 trials, the Sparkle trial and treat to target trial. In both studies, it has been shown that there is no relation of lower LDL cholesterol with intracranial hemorrhage. Now, in Sparkle trial, there was 2% of patients who presented, who were enrolled, who had history of CVA and before and history of intercerebral hemorrhage were also included because they had potential to have coronary artery disease events. So it was seen that those patients who have a prior history of intracranial hemorrhage, the chances of having bleed in these patients were higher as compared to those patients in which there was no prior history, number one. Second is that like lacunar infarct, which Dr. Narsingan is talking about, the presence of lacunar infarct, it was found that hazard ratio was somewhere around 4 times more to have intracranial bleed as compared to those in which there was no intracranial. This was also from the Sparkle trial. This data was come out from that. So what LI has recommended that when you are bringing down LDL cholesterol to this, you do have to look into all these points which has been raised by the Sparkle trial. But you have to look into that how much the benefit in cardiovascular event reduction will be. If you think that cardiovascular event reduction is going to be much higher than the possible slight absolute increase. See, there are 2 points. One is the relative risk of intracranial hemorrhage or intercerebral hemorrhage, and that is the other is the absolute increase. You may have a minor increase in number of patients with intercerebral bleed, but the benefit in event reduction is much higher. So you have to look into this, and when the benefit is more than the harm, then you have to bring down the LDL cholesterol to the target as per the IACM risk category. If you think that benefit is not that much, like in mild or moderate risk group or a very high risk group, then you can take a balanced, individualized call, what should be the LDL cholesterol. But most of the observation and epidemiological studies shows 70 milligram as a borderline, where less than 70 milligram is associated with higher bleeding intercerebral hemorrhage, whereas more than 70% milligram is associated with lower intracranial hemorrhage. But these are all not RCTs which have shown that. This is all population-based studies which have shown that.
Yes.
More so from China and Japan and South
Thank
Korea.
you, sir. Thank you, sir.
I think we had an excellent erudite talk by Dr. Ramanpuri. And in fact, it was a lot of insight into the lipid management in our clinical practice. And thank you, Dr. Ramanpuri. I also thank Dr. S. N. Narsingan for his valuable cerebral thoughts on various the common clinical problems. And I also thank all the people who have interacted with Dr. Ramanpuri. And I also thank Dr. Parikh sir and M P Singh for this wonderful initiative to share the expertise and knowledge. It's a very common problem, CVD, where the dyslipidemia is a very common risk factor accounting for the CVD. Still in India, like we do have more people dying of CVD. I think it's a very good talk, and again extend my congratulations to Dr. Ramanpuri. Over to Dr. M P Singh.
Thank you, sir. Thank you so much. I would, before we end, I would like to invite our President, Dr. H.S. Pathak, sir, to propose a vote of thanks to everyone presented.
Good evening, everybody. Now it is my pleasant duty to convey my vote of thanks on behalf of Indian Association of Clinical Medicine. At the outset, I thank Dr. K.K. Parikh, who is our guiding force behind all these programs, all these activities of IACM. I am also thankful to Dr. Anil Kulusestra, who is the president of newly inducted Gujarat chapter. Dr. S.N. Narsingan, who is a great clinician involved in activities of API and IACM for years together, and Dr. S. Chandrasekhar, who is the secretary of the Tamil Nadu state chapter, which is also newly inducted, for his good moderation of the topic, and to the chairpersons for well-conducted meeting. And I thank Dr. Ramanpuri, who is the founder and chairman of Lipid Association of India, for his very comprehensive talk on lipid management. We all know all keys do not fit in all locks. So the Indian guidelines are very important for better management of lipid and reduce the mortality. I'm also thankful to Dr. Chawla, MPS.
Dr. Pathak, so you are now on mute. Please unmute yourself.
Who are present in the meeting, and also Dr. Suresh Kushwaha, who is a very dynamic secretary, and all the participants and audience in this program. I will fail in my duties if I do not thank Dr. M P Singh, who is the main focus or attraction for conducting all these programs. And without his much sincerity and activities, it could not be possible to arrange all these online programs. So I hope he will continue all such programs in the future also. And we are hopeful that we will continue such programs with much more and more participation from all. Thank you, everybody. Good night.
Thank you, everyone, for your active participation.
Thank you.
Looking forward to see you in all further meetings. Thank you, sir.
Thank you. Good night, everyone.
Good night. Good night.
Good night. Thank you. Thank you.
Good night. Good night.
Okay.